So second case, I had to run from one cath lab to the other here. So this is the second live case from our center. It's a 26-year-old female. She's a little bit tiny, weighing 43 kilos. She's a medical student, at least she was last year. Now she's the first year resident fellow of the surgical program in the countryside of São Paulo. She had been asymptomatic. A heart murmur was picked up during internship at the end of last year, and she's on no medication. On physical examination, she has the classic findings of an ASD, chest X-ray, there is mild cardiac enlargement and increased pulmonary vascular markings, RVH on ECG, as well as sinus rhythm. Next one. Next slide. You're going to see the pictures. There is right ventricular volume overload. The RV measured 36 millimeters in diastole, and there is two ASDs. One that is more anterosuperior, measuring about 18 to 20 millimeter. Another one more posterior inferior, measuring 5 millimeters. And these ASDs are separated by a flimsy tongue of tissue. You're going to see better pictures in a minute with Simone. Next slide. So this is the TE, both ASDs. On the left side, this is 0 degrees. On the right side, there is RV enlargement. Next slide, please. Then we went to 30 degrees on the left side, the two SDs, one more anterior, the other one was more posterior, and on almost 90 degrees as a transition between short and long axis, the SD measured about 18 to 20 millimeters. Next slide. This is our former fellow Fabricio, who hopefully presented some nice papers. He was having a nap in Argentina. Hope he's not like that in Frankfurt. Hope he's having a good time. Next one.
The guy next to him is also.
This is the. Yeah, and these are the 3D pictures, the largest ASD and the smaller adjacent ASD. So let's go live with Simone. She has some nice live pictures here. Echo, please. Echo on screen.
Okay.
There you go.
So. For chamber view, we see how big is the RV, the LV, the right atrium very dilated. On short axis, we see here the larger ASD. It's more anterior and superior than inferior one. They are close to each other. We measured here the larger one was about 18 millimeters. There is a 3 millimeters tissue between them, and the smaller one measured in this view about 4 millimeters. And so we can see here the tissue separated both of them. This is the bigger hole, SVCs here. You see left to right shunt. And let me show you some 3D pictures that we've just got. So this is the left side. This is the larger ASD. This is the smaller one. They have this tissue, this ring separating both of them. The tissue measured about 4 millimeters to 5. Another view here.
Simona, that's really very nice. We're just going to interface with the audience a little bit. If you just leave those pictures running. Rafael?
Okay.
Where is he? What's your approach here?
Close the big one only.
Yeah, good.
Okay. Caesar?
I think it's interesting to sizing and then see if you can close the smallest one with one device.
Yeah, okay.
Dr. Malakan?
No, Rafael again. Coming back.
Just to comment,
Hold on a second.
Just a second.
Raf?
by area, the small one contributes 1/16 of the shunt. So even if it remains open, it's meaningless, but it will not remain open.
What you're saying, Raphael, is the perimeter parameter of the small one is very small compared with the perimeter parameter of the large one, correct?
Yeah.
Malakan.
I think according to the literature, I'm saying if the distance between the two defects are less than 7 millimeters, then we can close it with just one occluder, but larger than the large one.
Okay.
Sounds good.
Francisco, you were awake this time, so what would you do?
Well, I'll do the same. I'll put a balloon and size the bigger defect. I'm pretty confident that with just one device you can cover the both.
Okay, good, thank you. Right, Carlos, that was the view you heard from everybody here.
Yeah, very nice comments, and we must say we agree with all comments. We did the stretched diameter. We went through the larger defect. Let me show you the picture, Simone. So I went to the SVC, rotate the catheter. It went through the superior hole easily. So I had the wire. Let me show you that picture. There you go. It's the larger defect, and the wire is sort of pushing that flimsy tongue of tissue inferiorly. Next one, see?
That's a nice picture.
And then we did the stretched diameter. Very nice picture. Then we did the stretched diameter. We got about 25 on 2D echo, and on Cine we had 26.2. This is the. We've been doing this. We've been taking those pictures that you see on screen to assess the area of the balloon. On this picture, we had two diameters. It's sort of circular, 24 and 23. More or less, and then with the balloon up, we reassessed the significance of this adjacent ASD. So Simone has some more pictures. Go ahead, Simone.
Okay, let me see this one. So we see here the balloon, and then the inferior defect. I think it's much more inferior than before. It's like the balloon is compressing the septum down, and the distance looks a little bit bigger. It's bigger than before. Then we did some 3D images. I'll show you another one that we got here. So you see here, this is the balloon here, right here, and this is the smaller defect, the inferior one. So this is the distance. It's not compressing, but I think it's a very small defect.
Gianfranco.
Yeah.
What you've seen so far, comments or questions?
Hi Carlos and Simone, Gianfranco Pedra from Milan.
Hi Gianfranco.
Nice to see you.
Yeah, I'm rooting for Italy, huh? I'm rooting for Italy in the finals.
Yeah, my comment was concerning the second hole when you was performing the balloon sizing. It looks that this flimsy tissue is pushed a little bit away, and probably you will be able to close with the rims of the discs even this second hole. And even if you will have a small residual shunting through it, it will be not very important, because here the physiology is the ASD closure and the right ventricular overload.
Okay. All right, Carlos.
100% agree, Gianfranco.
Yeah, your next step.
Yeah, Zach, I agree with the panel. I agree with Gianfranco's comments. So we decided to go with a single device. I didn't even bother to go through the second hole. I could have done that while my balloon was inflated. I think it facilitates crossing the second defect, but I haven't done that. So I crossed the iterator septum with a 14 French sheath, and because the stretched diameter was anywhere between 25 and 26.5, we picked up a 27 device. Right. This is a Figulla device.
Carlos?
This is not fenestrated. This is a regular Figulla device.
Carlos,
yes.
One quick question. And that is, do you balloon size all the time, or is this because of the two defects you're balloon sizing?
very good question, Shaq. In about 50% of our patients, we haven't been doing balloon sizing. If the septum is sort of thick, it's a straightforward ASD, we overestimate the size of the device by more or less 20% of the maximum diameter of the defect. When the septum is floppy, there is some concerns about the distensibility of the septum, or when there is another hole, such as in this case, then we do balloon sizing as Caesar had recommended before.
Okay.
So I'm not sure how many of you in the audience do balloon sizing routinely, but we go more or less half and half.
In this particular patient with two defects, with a little bit of separation, balloon sizing first of all. Show of hands.
Yeah, everybody. Just
okay,
about.
And those who would not balloon size?
One at the back. Two, no, some over here. Okay, good.
Okay, a very small minority would not balloon size. It was a close minority, I guess, but still, a majority went for balloon sizing, Carlos.
Yeah. Actually, we could ask Carlos.
Yeah, good.
Carlos, you have a lot of experience with the
very
Figulla
reassuring
device. You have a lot of experience with this device, and maybe some of the audience too. Now, Ziad Hijazi gave an excellent talk yesterday based on the FDA panel with St. Jude and other manufacturers about the risk of erosion with larger devices, I think bigger than 26. This was 27, did you say?
Yeah, it was a 27. We had the strata diameter 26.4. So I think I'm within a very safe margin. Would you guys had picked up a smaller device?
Was that your question or your question?
No, the question I was going to ask, have you or has anybody in the audience had problems with erosion with this device?
Anybody?
Well, not yet, Neil, not yet. We've done maybe anywhere between 60 and 70 cases of the ASD of the Figulla device. I think the numbers are too low to make robust comments. I think eventually someone will have an erosion with a Figulla device. I think just because the numbers are not there yet.
Well, I
that's
just
my personal bias with no evidence-based medicine.
And this is a, although you've got some aortic rim, I thought, looked not bad.
Okay, carry on, Carlos.
Yeah, I agree. Yeah, well, my sheath is crossing the interatrial septum. It's still in the left upper pulmonary vein. The device is well attached, as you can see. I'm pulling it back. I think I'm kind of close to the mitral valve. I'm going to rotate the sheath a little bit posterior clockwise rotation. Yeah, I'm away from the mitral valve. So I'm opening up the left disc. It's sort of bulky. When you see that, you just push your catheter and you smash the against the roof of the left atrium. Go ahead.
Can we see echo instead of your hands, please?
Perfect. Echo on screen. Echo bigger. There you go.
And
so, and fluoroscopy. Fluoroscopia menor, por favor. That's perfect. So I'm sort of away still from the septum. I'm opening up the waist to bring everything back. It's coming at a very nice angle. You see, the sheath is sort of parallel to the spine. That's the way to bring it more in a good angle. So I'm going to open up the right disc here in the usual fashion.
Looks lovely.
Okay,
looks very nice.
Good. Yeah, the orientation is very good. What I like about the Figulla device, it's very, very. It's not very flexible, but it's more flexible than the Occlutech device. So I'm not sure if this will have an impact on the rate of the erosion. Personally, I don't believe. But in terms of manipulation, it's a very nice device to work with, especially in adults with very large defects. And well, let's see the echo pictures. I think the device is in the right spot. The question here is if it did cover the second hole.
Also, Carlos, when we get to the release, can we have the fluoro big and echo small for the release? Because it'd be interesting to see how much movement there is after release.
Okay, I'll do that for you, Shaq.
So I think the device is in a very good position, and I can't see any residual shunts in the inferior part of the septum. So I think it covered. The only shunt we see here is that shunt that we usually see while the device is still attached to the cable. So I believe when he closes that, when he releases the device, it will be closed. So I think it's a...
Can we take some 3D pictures, Simone?
Sure, we'll do that now.
Can you move the bioptome where it's fixed to the Figulla device? Can that help in getting the angle to a better position, and then see if there's no longer any flow visible?
Do you want them to pull the right atrial disc? Is that what you're suggesting, or rotating it?
I don't know this system so well, but I would guess that you can move the angle between the bioptome connection to the Figulla disc, and by doing that, maybe you rotate it in a way that if later on the disc is in a different position, the leak should be gone completely.
Okay, do you understand that, Carlos?
Yeah, well, I'm not sure about that. Let's have Angel bigger, just to show you. Angiografia maior, por favor.
And if they're going to show faces,
maior.
Keep Simone's face on,
yeah.
and not yours, Carlos.
Yeah, well, you see here we have a very good angle. I'm not sure if we rotate. I can do that live to see if it changes, but let me see. I've never done that, to be honest with you. I think there's a torsion of the wire mesh while we do that. I'm not sure if this works. There is some pivoting system between the tip of the pod and the device itself, which is good, right? But in order to bring the device more parallel to the septum, I think you have to rotate the sheath, not the delivery cable.
Okay, so are you happy with
have you taken some 3D pictures?
Images?
Yeah.
Yeah, I think so. Simone is going to show some 3D pictures. Echo bigger, maior, o echo, por favor. Echo, there you go. Then I will release the device with the Angel bigger, and then we're going to go for reassessment of the final position of the device after release.
So here we have the left atrial disc. It's very well seated, as we see here. This is the right side. And I assessed again with color Doppler, and I can't see any flow down here. So I think it covered very well. So I think the device is occupying almost all of the septum she has.
So
She's
good.
Small.
So I turn the safety knot, the red safety knot here. Yeah, fluoroscopia maior, por favor. Fluoroscopia maior. There you go. I'm going to do some zoom here. I'm going to bring you closer. I think this is good. And I'm going to do that under Cine to release the device. It's not coming. It's only a matter of rotating.
Rotate a bit, yeah.
Yeah, it's going to come. That's why I didn't like to rotate. There you go. Beforehand.
Very nice.
So it's been released, and
Simone,
yes.
echo bigger,
could
echo
you show
maior.
us a four-chamber? I just want to see the mitral valve.
Sure. I'll go back. Okay, here, that's the mitral valve,
Yeah.
that's the device.
Yeah, close but clear,
That's fine.
I think. Close but clear.
Yeah.
That's very nice.
Did we cover the second hole?
Yeah, I think we covered. Let's see here.
quick color
You see,
picture
when
and then we'll
the
leave you.
device was released. Yeah.
Yeah. Some color. Yeah,
see?
the second hole is there.
It's up.
It's being covered.
It's here. It's covered.
Okay.
Some 3D.
Oh, here we have
There
some.
it is.
We have another hole there.
Okay, it's here.
Forget it.
You see here?
Yeah.
Yeah, the area
Probably you
parameter
haven't
suggests
seen that
even,
before,
it's
but
even
I
less
don't.
than that, 16% that Raphael calculated.
Yeah, I don't care about this tiny defect in the posterior inferior portion of the interatrial septum. I agree with everybody there, especially with Gianfranco.
Simone.
Let's see the 3D.
Okay.
What is that, Shaq?
All right, a very quick 3D then.
Okay.
Okay, sorry.
So in this view, it's hard to say where this tiny. Oh, maybe here. It's hard to say, but I think there is something here left. You see here? Very close to the IVC. So that's IVC here, SVC is here, and here, that's the
Yeah, maybe with ongoing endothelialization, we can get this thing closed down on the road. So, Shaq, we are done here. I would like to thank you the opportunity for being live, and we are ready to leave.
Okay,
Thank you,
Carlos,
guys.
Simone, and the rest of the team, thank you very much for those two excellent cases. Excellent demonstration, excellent teaching. So thank you and congratulations to the whole team there.
Yeah.
Well done.
Thank you. I would like to thank Rodrigo, my anesthesiologist, my fellows, and all the crew. It's a Saturday here. The Brazilians don't like to work on Saturday. We are not like the Germans.
they don't like to
but
work at all.
anyways, bye-bye. See you soon.
Bye.
Yeah, bye-bye.